Respiratory, let's hear those sounds. Let's hear those sounds. I hear those sounds. I hear those sounds. Here's those sounds. What do you hear? They may not be that obvious to you, this sound, but what is it? It is a sound that sounds like bronchial breath sounds. What does that mean, bronchial breath sounds? Well, the most accurate test of anything in the chest is a chest x-ray, chest CT, chest x-ray, and chest CT. And the most accurate test is chest x-ray and chest CT. And anything that we're going to ask about in the chest that has a sound is probably going to end up being pneumonia, right? So bronchial breath sounds, also known as tubular sounds, are high-pitched sounds that's heard over the sternum, and they has some clear inspiratory and expiratory components because they're caused by consolidation. They're the increased transmission of sound that's through the bronchial tree, and it sounds like fluid going through a tube. So let's have a little agreement here. No matter what it sounds like to you, you're going to agree with our definition. The textbook definition of what a bronchial breath sound or tubular sound is. It's going through the bronchus, which is acting as a tube. The bronchus is a tube, and it's surrounded by consolidation. And the chest x-ray and the chest CT, welcome to being a pulmonologist. It's going, yeah. Now, chest wall percussion, we don't do too much chest wall percussion anymore. But chest wall percussion is a way of looking for consolidation. You just tap, 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 tap. Man, I can't remember the last time somebody was tapping chests. Tapping chests is a leftover, really. Now, the respiratory section is going to have a lot of things that when you get onto the floors as a third-year student, you're not going to see people doing. But just because you don't see them doing it doesn't mean that you're not supposed to be trying. So bronchial breath sounds, yes, you're doing auscultation. You're not just walking in and saying, I'll have a chest x-ray and a chest CT. And chest wall percussion. Doneless to percussion means consolidation. That's what chest wall percussion means when it's abnormal. First, okay, it means consolidation. Hyperresonance is like emphysema. So the most accurate test on to confirming the diagnosis is imaging of the chest. So here's chest wall percussion. Yes, I'll feel it tapping. Then gently there came a tapping at my chest wall door. Quote my doctor, nevermore. Tapping on the chest wall with the hands and the fingers and giving them the middle finger. Here, anyway, let's tap on the chest wall with that middle finger and striking it there so that you can see whether there's density or not. Dullness to percussion is consolidation. Consolidation with gooey stuff like pneumonia. Consolidation like an effusion. Consolidation like squished lung with atelectasis. Consolidation like infection, mucus, fluid, goo, liquid in the chest. Dull. And hyperresonance is a pneumothorax, COPD, emphysema. In other words, less dense lungs. Sounds more like a drum. Less density sounds more like a drum. Pneumothorax and emphysema sounds more like a drum, man. And that's hyperresonance. Well, we're in the pulmonary section. We're in the respiratory section. So give me a time not to say chest x-ray or chest CT, because we are, after all, in the pulmonary section. So chest wall tenderness, that's not quite percussion. You see, chest wall tenderness is just pressing and pressing. Ooh, you know, there's not that many things that cause actual wall tenderness. Does pneumonia cause chest wall tenderness when you press on it? No. You see, this is a big difference. You see, dullness to percussion, effusion, pneumonia, consolidation. But actual tenderness of the wall, where the ribs hurt, ooh, not too many things do that. Not too many things do that. Chest wall tenderness can be bone abnormalities. Chest wall tenderness is from inflammation. So anytime you see inflammation, you should say anti-inflammatories like non-steroidals, like anti-inflammatories from non-steroidals. Chest wall tenderness. You're pressing on the ribs, so it must be rib tenderness, like costochondritis. Rib tenderness. Remember, chest wall tenderness is much more important for the things that don't have tenderness. In other words, tenderness actually is good. It means you don't have a lot of serious things like going to die of a myocardial infarction, like pneumonia. And it's just inflammation of the joint, the chest joint. See, the reason that you don't think about it is that you don't know how much your rib cage moves when you breathe. You haven't quite realized that, like, but why don't you tighten down your chest and try and breathe without your chest wall moving? Wow. And you'd really see that chest wall tenderness is a rib problem, and you don't realize how much your ribs move every time you breathe. Non-steroidals are anti-inflammatory of the chest wall and help you to overcome the inflammation of those ribs. Occasionally, rarely, almost never, you give them a shot of steroids because it's inflammation. Now, Cheyne-Stokes respirations. Well, Cheyne-Stokes respirations, what do they mean? What does it mean? Cheyne-Stoking is a pattern of cyclic respirations where you breathe fast and then you don't breathe at all. Looks like you're about to die. You know why it looks like you're about to die with Cheyne-Stokes? It looks like you're about to die because you're about to die. Cheyne-Stokes is a nearly terminal respiratory breathing pattern. You breathe fast, then you stop breathing, and then you look like a fish that's just been thrown on the shore. So it's oh, it's terrible to watch this. Looks like people suffocating. Do you know why it looks like somebody is suffocating? Because they're suffocating. It's terrible. That's Cheyne-Stokes respirations. And basically what's happening is your medulla is in the process of dying. And you get to the point where it's like the safety on your breathing. Like, why can't you just hold your breath to commit suicide? Because CO2 would accumulate and force you to start breathing again. So when Cheyne-Stokes respirations are in the question, it means severe injury to the brain. There's a stroke, there's hypoxia, meningitis, infection. I mean, you just can go through and name all the things that basically mean I've just destroyed your brain. And the brain stem is holding on by its fingernails. So, like, for instance, barbiturates can kill you from respiratory toxicity. So do opiates. Opiates kill you from shutting off respirations. Alcohol, seizures, and shutting off respirations. So these intoxications will kill you by damaging your brainstem to the point where you have interfered with the respiratory centers and you're about to die. And that's how these toxicities work. And so it means that you're dead. You stop breathing, but your body picks up the toxicity of the CO2 at the end and sort of sends you in some emergency breathing at the end. But it's not pretty. You look like you're suffocating. You're intermittently dying, but your heartbeat's okay. And this breathing precedes death. If you've been around as many people dying, that's what you're going to be a doctor for. Well, This is a finding. Why is it that you get clubbing when you have chronic respiratory illness? What makes you get clubbing? I know you get hypoxic, but why does hypoxia make your fingers big? Are you going to breathe through your fingertips? Why does hypoxia, why does chronic lung disease make it so that you are clubbing? And the short answer is, we don't know. But we do know that chronic hypoxia from lung disease, makes your fingertips big. Chronic hypoxia from lung disease makes your fingertips big. The mechanism of why the fingertips is not clear. Because if I said, why does that happen? People go, well, hypoxia. Yeah, but why hypoxia? Why doesn't your ass get big? Why doesn't your penis get larger? Okay, why is it that you have to have it, that your fingertips get big? So you just have to say, I don't know, and then maybe we'll find out someday. Mostly, you know why we don't know? Because it doesn't matter that much. It doesn't matter that much. We haven't figured out one of the tips of the fingers, and all we can tell you is that all you can do is correct the hypoxia, and that's it. Clubbing. What do you see? Stop. What's that sound? It is crackles or crepitations. For those of you who have hair, take your hair and rub it in between your fingers so that you can listen to what hair sounds like, or hear. Anyway, take your hair and crackle it up in between your fingers. Yeah, so crackles or crepitations, they're the sound of lung disease, and they're the sounds of alveoli popping open like popcorn. So the diseases associated with crackles is pneumonia. So they sound like hair. Rub your hair. Come on. In between your fingers. And it's heard during inspiration. Remember, wheezing is heard during expiration. Wheezing is expiratory sounds like a flute. Wheezing is an expiratory sound. This is like air bubbles popping open as the lungs fill up with air and they open with a pop, 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 pop. Crackles are caused by the sound of alveoli opening. And remember, the smaller it is, the harder it is to open. As it gets larger, they pop open more because there's our friend, the law of Laplace. Now, excessive airway secretions makes it so that you have more pressure on the alveoli, so the popping is greater. That's why consolidations of infections end up causing these crackles and crepitations and popping, because it is a sign of fluid in those lungs, pulmonary edema, and especially pneumonia. Anything that makes the lungs denser, it goes pop, like exploding popcorn. Next one. What's that sound? So this one is egophony. Ooh, egophony, bronchophony. Great names, right? Well, egophony and bronchophony are sounds that were more important when you didn't have an X-ray and a CT machine on every street corner. When you had to examine people and say, do you have consolidation? These are signs of consolidation. They are things where you go, E, and it sounds like A, and then say E, and it sounds like A, E, A, E, A, E, A. Yeah. So E to A changes, and they're sounds of consolidation. And also, which transmits sound more? Air-filled lungs or fluid-filled lungs? Which is going to transmit sound more? It's actually a fluid or dense lung transmits sounds more. So normally, if you're listening to somebody's chest and they're speaking and they're going, hola, that means hello. Okay, you shouldn't hear it. So but if you hear it and you put a scope in there and you go, hola, that means hello, and you can hear all of that, That means that you've got an increased density of lungs that's abnormal. You should not be able to hear things that much in a normal air-filled lung. It is the respiratory section. So egophony and bronchophony are diagnosed with chest X-ray and chest CT. Bronchophony says normally spoken words are soft and indistinct, except when the lung is condensed and solid and it transmits more. It sounds louder because there's a greater force of vibration that can pass through solid material. And egophony is when you ask somebody to say, E, and it sounds like A, E, A, E, A, egophony. We should call it egophony, don't you think? If it was called egophony, then it would sound like E to A changes. And again, these are signs of consolidation, pneumonia, effusions. Consolidation have an increased density, and the greater the density of lung, the more solid, the more it transmits sound compared to air. Air doesn't transmit the sound as well inside a lung. It just doesn't. Dampens the sound. But that's why these are just two different ways of saying increased sound, so it sounds louder, and E to A changes. Chest X-ray, chest CT. Our next respiratory slide, here we go. Kussmaul breathing, physical finding. What changed Stokes was you stop, that's like zombie breathing. And Kussmaul is getting laid in the backseat of a car breathing. Fast, deep breathing, defined as rapid, deep breathing, faster. Gonna breathe myself now, faster. Having acidosis, faster. And I'm breathing respiratory compensation. DKA, lactic acid, methanol and ethanol, and ethylene and glycol. Rapid deep breathing, Kussmaul. And Kussmaul's breathing is regular deep inspiration with a tidal volume and the alveolar ventilation are up. Now remember that you're going to see this later on when we do physiology more, is that increased rapid deep tidal volume means more alveolar ventilation, and alveolar ventilation is the one we really like because that's the one that really exchanges gas. That's the alveolar ventilation is the one we really like because it's the one that really exchanges gas. So alveolar ventilation is de bueno, bueno, bueno because we want the ones, there should be no alveolar ventilation. Alveolar ventilation should be where everything really hits in alveolar ventilation. Now it can be fast or slow. Most of the time it's fast, but it's regular deep breathing and usually is part of respiratory compensation. But the minute ventilation goes up, you see, respiratory has all these words for it that's unique to it. Alveolar ventilation is where the gas really exchanges. Minute ventilation is like saying cardiac output for the lungs. Respiratory rate times alveolar respiratory rate times tidal volume. Respiratory rate times tidal volume. Minute ventilation. Alveolar ventilation is the part really gets down there to the respiratory zone. And it's usually compensation for an acidosis of any kind. Meaning you can't tell when somebody has Kussmaul's. Is it diabetic ketoacidosis? Is it lactic acidosis? Is it methanol? Is it aspirin? Is it uremia? You can't tell. You're just breathing deep as a part of acid stimulating the brainstem. Remember, what are those three stimulants to breathing? Acid, carbon dioxide, hypoxia. Acid, carbon dioxide, hypoxia. Which of those is the weakest? The weakest is hypoxia, because hypoxia doesn't really kick in until you get peripheral chemoreceptors. And peripheral chemoreceptors, remember physiology, okay? Peripheral chemoreceptors don't kick in till the PO2 goes less than 60. So the peripheral chemoreceptors are in the carotid, the aorta, the carotid, the aorta, the carotid, the aorta, less than 60. But acid, and especially carbon dioxide, central chemoreceptors, brainstem. And central chemoreceptors in the brainstem are much stronger. You can't overcome them very well. Now, it's a direct effect, that Kussmaul's breathing, of salicylates, because salicylates cause both metabolic acidosis, which we're going to compensate for, and they directly stimulate the brainstem and make you breathe faster. So the moral of that is, treat the underlying cause. In this case, alkalinize the urine for excretion. Alkalinize the urine for excretion. Isn't it exciting? Welcome to the next section of the respiratory section. Some of these breath sounds are going to sound the same for many of you, and it's going to be difficult. It's hard to understand tubular breath sounds and vesicular breath sounds. I understand. It's a bit subjective, and I understand that. So you're going to try the best you can, and just remember, if you're confused, everyone's confused with you. Let's listen to this one. So this one is a young man who comes to the emergency department. He's got chest pain and a fever, and he's got pain that is going to be sharp. Sharp means not ischemic, so that's the first part. Also, the other reason you know it's not ischemic is because we're in the respiratory section, not the cardiac section, and it worsens with lying flat and with inspiration. So ischemic pain is not positional. Ischemic pain is not pleuritic. Ischemic pain is not positional, not pleuritic, and not tender. The diagnosis for this person, when he's got sharp pain that worsens with lying flat, this is the same thing as saying gets better when he leans forward, gets better when he leans forward, and that's pericarditis. Pericarditis has an extra heart sounds, and the sounds are the rubs. What's the most accurate test is EKG for pericarditis. Now remember, constrictive pericarditis, even though it uses the word pericarditis, constrictive pericarditis is an anatomic problem, and that was diagnosed with CT and MRI. It's okay, constrictive pericarditis is an anatomic problem, but pericarditis is diagnosed with EKG, and the causes is most often viral. So pericarditis, sharp, aye, like being hit by a knife. Ow, like taking an arrow in the chest. Ow, pleuritic pain. Worsens with leaning back is the same thing as saying better when you lean forward. Worse when you lean back, better when you lean forward. And the rubbing off. And the rub has three components, and that's what we're trying to play for you, a pericardial friction rub. I hope you can appreciate it. I hope you can hear it. Pericardial friction rub. Now that pericardial friction rub is scratchy or leathery or rubbing against it. And the most accurate test, the EKG has ST segment elevation everywhere or PR segment depression. ST segment elevation everywhere and PR segment depression. PR segment depression, remember, not prolongation, but depression. Depression. PR segment depression. And remember, later it goes through an evolutionary pattern just like a myocardial infarction. First we have ST elevation, PR segment depression, and then later on the T waves invert. And that is what you're going to have here with pericarditis. The most common is virus, but remember, any infection could cause it. The most common is viral, but remember, any infection could cause it, because really it comes down to the fact that, well, just like pneumonia, you could have streptococcus causing pneumonia, but you could have streptococcus causing pericarditis. You could have staph causing pneumonia, and you can have staph causing pericarditis. You could have viruses causing pneumonia, and you can have viruses causing pericarditis. So the same way almost any infection of the lung inflames the pleura, that same inflammation can go through to the pericardium. The same way that lupus can cause a pleuritis, lupus can cause a pericarditis. This is inflammation of the pleural and pericardial surfaces. Next one. What's that sound? So bronchi are, well, the most logical question is, What's the difference between rhonchi and crepitations? What's the difference between rhonchi and crepitations? See, what's the difference between rhonchi and crepitations? Well, they're very similar, except rhonchi or rhonchus, rhonchi, which is plural, rhonchi is really a lower pitched sound, and also it still tells consolidation. But this is where I said, well, isn't this one of these fuzzy things where if you actually asked me to give you a precise definition of the difference between crepitations and rhonchi, the pitch is lower of rhonchi. They're both with consolidation. And rhonchi is more liquidy sounding and not as high pitched as wheezing. They're both during inspiration, both rhonchi and crepitations. But if crepitations sounds like Velcro, pop, 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 rhonchi is more low-pitched, guttural sounding, gurgling, yeah, like bubbles going through water. It's a good name for it. And you say, well, does it mean something different? No. Rhonchi and crepitations have almost the same meaning, which is to say fluid and consolidation in larger airways and association with inflammatory secretions and drowning, but more secretions than pneumonia, rhonchi. So with all the excess of inflammatory secretions, you have a lower pitch sound because it's going through larger airways. Crepitations are the sound of alveoli opening. Rhonchi is the sound of air going through bronchi. Crepitations is the sound of alveoli opening. Rhonchi is the sound of airs going through bronchi. And that's the difference. Clogged up mucus going through an airway is rhonchi. Crepitations, popping open alveoli, that is pneumonia. They're close to the same meaning. Meaning you have a consolidated lung. But crepitations, alveoli, rhonchi, airways. And that's the difference. Time for something completely different. What do you hear? What do you hear? What do you hear? What do you hear? It's stridor. Stridor sounds like you're being suffocated to death. That's what stridor sounds like. Stridor sounds like a person who's about like you're being strangled to death, man. It's disgusting. Stridor. Stridor is epiglottitis. Stridor is terrible children who are about to be suffocated to death. The high-pitched sound on insulation. You hear stridor. You don't need a stethoscope to hear stridor. Stridor is something you come in the room and you think the kid's about to be intubated and die any second. It's a sound that has the same pitch and intensity because in and out, but the point is stridor is a laryngeal problem. It's here. Rhonchi is down here, crepitations is down here, but stridor is up here. That's why it turns your throat into a musical instrument where the sound is death. And it's caused by narrowing of the extrathoracic. That's what I call my throat, strangling me to death in my own throat. Yes, it's strangling you to death in your own throat. Epiglottitis, vocal cord paralysis. It's up here and you don't need the stethoscope. You should walk into the room and find it. Like allergic reactions making the vocal cords tight and narrow. And stridor is a disaster. Stridor is someone who needs, I would call everybody, I'd call respiratory, pulmonary, and ENT all at the same time before the kid drops dead and turns blue. Tracheostomy, epinephrine, oxygen, steroids, everything, 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 everything. Stridor, upper airway. Stridor, suffocating. Stridor, you don't need a stethoscope. Stridor, epiglottitis. Stridor, this is what you're supposed to get at your level. At your level, you want this. You know what? People give too much information, so I'll give you the right bottom line of our stridor. Disaster! The kid's going to die. Thank you very much. Next. Subcutaneous crepitus is a popping in the skin. You can actually feel it. It feels like Rice Krispies. You know what Rice Krispies are? Anyway, it's like squeezing on your Cocoa Puffs, and you feel it. It's in the chest, but it's palpatory. Subcutaneous crepitus is palpatory. It's not a sound. It's a feeling. It's a feeling, and it happens when you have air underneath the skin. It's usually from the lungs popping. And it's usually a sign of barotrauma. In other words, pressure of air going through the chest and causing you to have air popping through your skin. It's totally and utterly disgusting. Like, that's why I play with it a lot. When I see it with people, I go like, pressing on it, like, wow, that's so cool. Holy crap, man. Whew, I hope it doesn't happen to me. So it's a palpable feeling. It's not a sound. It's a feeling. It's like bubble wrap. You know bubble wrap? They like to crack, 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 crack. Bubble wrap. Stepping on bubble wrap. Pop, 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 pop. But it's a feeling of subcutaneous air in your skin where you're pressing on the skin. You feel it popping. And so you put in an endotracheal tube, and the pressure pops it open, and it's associated with these wounds and rupture and air dissecting through tissues. It's air dissecting through tissues that causes gas. Not gas forming like you have Clostridium. Not gas forming like you have Clostridium, like it dissects through. That's a kind of an infection. That's a kind of a pregangrene, gas-forming infections. So most subcutaneous emphysema we have now is not from gas-forming organisms. That's a real rarity. It happens from an adverse effect of too much medical care. You intubate someone and it pops open something somewhere. Okay, so we don't see it. I mean, yes, it's true that infections and gas gangrene can cause it, but you don't have to worry about those people because those people are about to die. Subcutaneous emphysema is a feeling in the chest, ruptured esophagus. For an infection, it's a super emergency. You're about to die any second. But for the subcutaneous emphysema, from trauma, barotrauma, intubation, popped lungs, it means you need to adjust your tube. It's a feeling. Feeling. Speaking of feelings, what is that? Ooh, let's hold hands. Ooh, tactile fremetus. I feel the vibration. You've got a vibrator in your chest. Ooh. Yeah, what's tactile fremetus? Ooh, tactile fremetus is a feeling of consolidation as people feel the sounds going through them. It's a feeling of sound being transmitted into my hands. Increased density of lung increases tactile fremetus. Tactile fremetus means grabbing your vibrator by the hand. That's what fremetus is. You feel, haven't you thought of changing the AA batteries? So tactile fremetus. What increases, what decreases? More consolidation increases fremetus. Less consolidation decreases fremetus. Tactile fremetus is the palpable vibration. The patient speaks, and you can literally feel the vibration through the chest wall. When lung density is increased, more vibrations are transmitted to the chest wall, and fremetus is increased with more vibrations as it goes through. You put your hands on the chest wall, you feel for the vibrations, the patient says the words, we say 99, but it could be anything, and you feel the increased vibrations from the chest wall. Now, when the lung is separated from the chest, too much air or too much fluid? Too much air, too much fluid. Too much air, too much fluid. You don't feel the vibrations as much because the liquid deadens them and the pneumothorax deadens them. So they're increased by lung consolidation and decreased by air from the pneumothorax and decreased by pleural effusion as it goes through the chest wall. Fremitus. Now, I could continue to ask you what's the best initial test, most accurate test, but for almost everything here in the entire respiratory section, the answer is chest x-ray, chest CT. Chest x-ray, chest CT. How come not an MRI? Because MRI is based on water density, and the water density of most soft tissues is about the same. So it's not like the brain and the bone, which is markedly different water densities. These are the densities of where everything is about the same. So when you have emphysema emboli, you don't feel the vibrations coming through as much. Who's this dude? What does he have? As if you see, if you put those little things over his eyes, you won't even know who he is, of course, right? So this is a guy who's in a tripod position. This tripod position where you're leaning with your hands. Like you see, if you're out of breath when you've been running, you see runners, and then when they finally are going to stop, this is the position that holds the lungs open the most. And that's a tripod position from emphysema. Because it literally holds your chest wall open the most. And that's why it is that runners should walk it off, but if they're really super exhausted, they're leaning forward. That tripod position is the maximum way to open the lungs. The test, of course, is a chest x-ray and a chest CT. You lean forward because you're trying to augment breathing, and it actually pops open the rib cage so you can get a breath in. And we can use the words COPD and emphysema essentially interchangeably. COPD and emphysema for us are interchangeable terms. They mean hyperinflation, flat diaphragm, hyperinflation, flat diaphragms, increased residual volume, increased total lung capacity, increased residual volume, increased total lung capacity, and flat diaphragms, because all that extra space is dead lung called residual volume. The chest x-ray shows flattened diaphragms, and here's the biggie. Pulmonary function tests show decrease in FEV1 and a decrease in the ratio of FEV1 to forced vital capacity. What test becomes abnormal first in COPD? The one that becomes abnormal first in COPD is called the FEF, Forced Expiratory Flow 2575. FEF, Forced Expiratory Flow 2575. It's the middle part of the breath. The middle part of the breath. FEF, Forced Expiratory Flow 2575. The middle part of the breath. It's the mid-maximal flow. That's what's first. That's what's first. And then the FEV1 goes down. The force, and this takes advantage of things like elastin fibers are destroyed, you can't exhale. Elastin fibers are destroyed, you can't exhale. Extra compliance, you can't exhale. Next one. What do you hear? So, it's very hard, this is the hardest one, to be able to say what was the difference between tubular breath sounds and vesicular breath sounds. That was the hardest one. It was hard to know that vesicular breath sounds are also a sign of lung illness, and vesicular breath sounds are a sign of lung consolidation almost at any point in auscultation. Vesicular breath sounds. This is a bit poetic, don't you think? Okay, it's most clear at the bases and least towards the apex because the lungs are thinner at the apex. It's a wishing sound with the long inspiratory phase and a short expiratory phase. And what does this mean? What does this mean, really? Not too much. It can be, in fact, normal. So how are you going to tell the difference between that and a tubular breath sound? Well, it's another measure of consolidation because it's going it's not bad, actually. It's not bad. It's not as bad. It's not as bad as this one. It's not as bad as wheezing. Wheezing are expiratory sounds. Wheezing is always evil. Wheezing is a high-pitched sound, expiratory. Wheezing is caused by asthma and bronchoconstriction. Wheezing, the most accurate test is pulmonary function testing. What part of pulmonary function testing? Pre and post bronchodilation, methacholine stimulation, pre and post bronchodilation, methacholine stimulation. Wheezing is expiratory, high-pitched. You're in deep poo-poos, man. Because it's a high-pitched, this musical quality. I hope I never go to a musical. It sounds like this. What's the musical called? I'm Gonna Die. That's the musical called because it's expiratory sounds where you have bronchospasm and expiration, and it's caused by narrowing of the airway, turbulent flow. And you know what what's worse than having wheezing? When the wheezing stops. What's worse than fighting in a relationship? Hello? 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 That's worse than fighting. Hello? This phone call has been disconnected. That's worse than fighting. So wheezing is expiratory. Wheezing is asthma. Wheezing, pulmonary function test. Pre and post bronchodilation, and also methacholine stimulation to make the diagnosis. Now, this is most often a bronchospasm is found in asthma. Sometimes the edema fluid. There is the cardiac asthma. This cardiac asthma, we have extra fluid building up in that chest, and you go, oh, there's wheezing because the bronchi are getting fluid. However, remember that the wheezes, when you hear them, are expiratory. The longer the expiratory phase, the worse it is, and it can be caused by sometimes, rarely, the foreign body partially blocking a bronchus, making us wheeze us. Now, the most accurate test is a pulmonary function test. And the pulmonary function test, you ready? Low FEV1. And here's the key word, reversibility. Reversibility. In other words, bronchodilators change it. Methacholine changes it because COPD does not change with bronchodilators. COPD does not change with bronchodilators. Bronchodilators change asthma. Final one, what is it? Final one, what do you hear? Pectoriloquy? What the hell is that? Pectoriloquy. I don't know what it is, but it's such a cool name, right? Whispered pectoriloquy. Whispered pectoriloquy. What does that mean? Speak to the penis quietly. Hello? How have you been? Whispered pectoriloquy. Do you know that you're not supposed to be every night? What is this whispered pectoriloquy thing? The whispered pectoriloquy thing. What's the most common cause of that? What's the most common cause of that? Whispered pectoriloquy. What's the most common cause of that? What the hell is that? It says that a normal person shouldn't be able to hear whispers through the lungs. You shouldn't be able to hear anything. Whispers should not be transmitted through lungs. So you shouldn't be able to hear anything. Speak up, Conrad! So you shouldn't be able to hear whispers going through lungs. When the patient goes, 2, 3, 1, 2, 3, you shouldn't be able to hear it. But when you whisper and the person says, I can hear you clearly, it means those whispered sounds are passing through increased consolidation. And this is the theme we've had the whole respiratory section, which is density transmits and the air does not. Now that's hard to understand because here we're speaking in the air. So you say, hey, what are you talking about? Air sets up vibrations for us. Yeah, but air's got to go through a chest wall, and transmitting it from air to chest wall, more density transmits it more. Whispered pectoriloquy transmits it more. It's a fantastic thing to have all these breath sounds and heart sounds and neurological things condensed together in one place. The physicality, the pathology, the pharmacology, the biochemistry to consolidate in one moment for a few hours to see all the magnificence of the human body in one cataclysmic consolidation. See you in the next course. Thanks for coming to spend some time with us.